Hello, class. Sorry I missed you guys this morning. I haven't been feeling too well. My allergies have been acting up really bad. I guess the pollen count's really high, so I just couldn't make it in this morning. So I decided to create this little short video, less than 15 minutes, to kind of briefly talk about what I would have given you in lecture today. I think when we left off last week, I was briefly talking about clinical prediction rules or the pragmatic application of clinical prediction rules. And I emailed everybody over the weekend the article by Flynn, Child, and Fritz. And hopefully you had a chance to briefly go over that article that I sent you. But again, just to refresh your memory, CPRs essentially are an algorithmic decision tool. They're designed to help you as future practitioners in three different areas or elements of CPRs. Tend to look at diagnosis. If you want to, diagnose a patient with X condition and they fit the criteria or they have the predictors, then, maybe you could diagnose them with that condition, like lumbar spinal stenosis, for example. Prognosis is another component where we look at outcomes, and then intervention, right? If I wanted to do X intervention, well, how would my patient respond to that intervention? By applying the clinical prediction rules and looking at particular predictors and see if my patient would have responded. And for our particular article, the intervention, of course, was spinal manipulation for nonspecific lower back pain. So when you look at CPRs are created by predictors or criterion, and they derive these predictors or criterion basically from the clinical findings. And those clinical findings can come from the history, signs and symptoms of the history. They could come from physical exam findings. They can come from orthopedic and neurological findings. They can come from specific diagnostic tests as well. And ultimately, when you put these findings together, they're going to have some clinical meaning or statistical meaning in some cases that can help you drive decision. So again, it's a good way of applying real-world evidence to improve outcomes, to improve quality of care. What I really like about it too, it really helps that novice doctor, that newly experienced doctor, to help drive some clinical decision-making factors as well. So at the end of the day, I want to point out, though, that they should not be used in isolation. You don't want to just rely completely on clinical prediction rules to drive everything that you do. And part of the old process of applying clinical prediction rules is when we look at those predictor values, the criterion values, we can often associate likelihood ratios to those predictors to look at the outcome for our particular diagnosis, prognosis, or intervention. So again, we use this value scale here, greater than 10, pretty good conclusive shift. That's most likely that is the direction that you're heading. 5 to 10 is a moderate shift, and 2 to 5 tends to be a small shift in probability leading towards that particular diagnosis or intervention. So I asked you essentially to read this article here by Fritz, Childs, and Flynn, looking at a pragmatic application of CPR in primary care to identify patients with low back pain with good prognosis following a brief spinal manipulation intervention. So this study really looked at two of those variables that are applicable for CPRs. It looks at the prognosis variable and it looks at the intervention variable, essentially. And pragmatic, right? Pragmatic means what's usual and customary. What do you typically do in a chiropractic office? Or what do you typically do in a clinical setting for lower back pain? And we're looking at physical therapists who essentially did the study, but they do spinal manipulation as well. So I think everything from the study can be extrapolated and applied to chiropractic practice as well. So again, I'm not going to go over the article per se, because hopefully you had a chance to read it. I'll just point out a few things from it, though. And one of the things I wanted to point out was, in this particular article, was Fritz and Flynn originally had, this article came out in 2005. I think in 2002 or 2003, I believe Fritz and Flynn published a previous article that had a 5 criteria component where they looked at the duration of current episodes of lower back pain, the evidence of distal symptoms, the FABQ. And the FABQ, or the Fear Avoidance Belief Questionnaire, really looks at the subcomponent of functionality. Segmental mobility testing and range of motion of the hip, specifically on internal rotation. So if the patient had this criterion and we applied this criterion to a patient with nonspecific lower back pain and they fit 4 out of 5, the likelihood of them responding to the intervention of spinal manipulation was favorable, and the prognosis for that intervention and the prognosis for getting their lower back pain better was highly probable. So then Fritz and Flynn decided now to do a pragmatic criterion because, in a busy chiropractic practice or in a busy manual medicine practice, you may not have time to do FABQs and check internal rotation of the hip. So what they decided to do was tease down the original criteria to 2 parameters, or to 2 criteria, or to 2 predictors, essentially, which looked at the duration of current symptoms of lower back pain, which were less than 16 days in duration, and looked at the extent of distal symptoms, not having symptoms past the knee. And basically what they were saying was that the patient presented with these 2 criterion from a pragmatic approach, and we applied a trial version of spinal manipulation, the prognosis was highly favorable. So if I look scroll down a little bit, and their intervention again was the HVLA. Theirs was more of a long lever manipulation, looking specifically at the SI joint in the lower back. But if we looked at the accuracy of applying both of these criteria, the accuracy of the 2 criteria rule and relative to the 5 criteria rule for predicting response to manipulation, it's still pretty favorable. Okay, still pretty favorable. The only argument there could be time. Time could always be a barrier for a busy practitioner. But at the end of the day, when we just looked at the 2 criteria rule for the success of spinal manipulation, the predictive values were pretty good. 7.2, right? A moderate shift in probability that the patient has a favorable outcome. So essentially, the results of the study indicated that there was a strong predictive relationship with the clinical outcome for spinal manipulation in primary care setting, and it suggested that patients with low back pain seen within this setting that presented with these symptoms with a couple of sessions of manipulation responded favorably. But I think more importantly, the coupled process of manipulation combined with exercise has very good prognosis for our patients. A lot of the evidence out there currently says manipulation is favorable. Manipulation coupled with range of motion exercises for the lower back is favorable even more. So again, at the end of the day, can you use CPRs in your own clinical practices to determine the outcomes for your patients? And what I'm trying to introduce to you here is another approach of driving clinical decision-making policies. And briefly, what I wanted to do also that was from an interventional standpoint. Also, I'm going to show you from a diagnostic standpoint. Let me just scroll down the slide. Here we go. So, diagnosis of pain originating from the SI joint. So now, we just talked about prognosis and intervention application of CPRs. This is the application of diagnosis here. So we want to determine whether or not diagnosis of pain originating from the SI joint. So if we want to diagnose a patient with SI joint dysfunction, can we truly use predictive variables to say that the pain is coming from the SI joint? So we looked at our predictive variables of a positive SI joint compression test, distraction test, femoral shear testing, positive sacral provocation test, and Gainsland's test on the right and left. So again, you guys should be exposed to these predictor variables here within your orthopedics course. And SI compression test, SI distraction test, femoral shear test, sacral provocation testing, Gainsland's testing, and ultimately the clinical bottom line here indicates that diagnostic of pain, or a diagnosis of pain from the SI joint, is highly favorable if a patient presents with 3 or more of these predicted variables. with a likelihood ratio of about 4.3. So again, moderate shift in probability for back pain, leg pain arising from SI joint. So again, what does that mean? Well, that means now if the pain is coming from SI joint from a physical therapy standpoint, what they would do is reference standards, send the patient to a pain management clinic, for example, for video fluoroscopy guided SI joint injections. Of course, for us, if the pain is isolated at that SI joint, why couldn't we engage in a trial of spinal manipulation with our patients as well? So again, essentially, the application here, the application here would be using these prediction rules, using these prediction rules to help essentially guide some decisions on how you want to diagnose the SI joint and maybe what do you need to do. So this comes from this article right here from Lancet, published in Manual Therapy, Diagnosing of SI Joint Pain, Validity of Individual Provocation Tests, and using those tests now to determine what the next outcome would be for your patient. So essentially what I wanted to do was show you how you could use the CPR to support, validate your diagnosis, but then also that can lead to maybe what's the next best intervention, right? So in this particular study by Lancet, they probably indicated at the time, referral to an SI joint injection under video fluoroscopy was evident, but our next step could be, why not do a trial of spinal manipulation for our patient? So what I'll do is I'll post these PowerPoints for you in regards to this article and in regards to CPRs, and hopefully you can take a look at that. And what I've done also is given you CPRs for different areas of the body, shoulder, cervical, and as we go through the course, I'll briefly kind of discuss each one of those and tie them back into, from an application standpoint in regards to what we're doing. So I hope this helps, and if you have any questions, please feel free to email me. Thanks. Bye-bye. See you guys soon.